management of type 2 diabetes, especially the early treatment intensification. This will be my agenda. I will give some introductive points about the prevalence of diabetes and the magnitude of the problem. Some points about the pathophysiology and a few points about the difficulties that facing us during the management of type 2 diabetes. Also, the latest guideline as regarding glycemic targets and the management plan. Few points about how to do early treatment intensification for type 2 diabetes. Unfortunately, the IDF lately declared diabetes as a pandemic of unprecedented magnitude, because it is one of the fastest growing health challenges during the 21st century. Here we can see the magnitude of the problem. Diabetes is spiraling out of control and it affects 1 in 10 adults, almost 50% undiagnosed. Currently, there is, what is the point? Currently, Currently, there is almost 537 million living with diabetes and projected to increase to 783 million by 2045. Also, it hits the poorest area and the hardest area, and almost 3 in 4 persons live in low middle income countries. Also, it claims life and causes premature death, and almost 6.7 million died from diabetes in 2021. It means 1 person every 5 seconds, which is a horrible number. This is the prevalence of diabetes all over the world. We can see here the percent of increase from 2021 to 2045 with a rate of 46% prevalence increase in diabetes. Also, we can see here in the MENA region, which comprises the Arab Gulf countries, now the current number of diabetics 73 million and projected to increase to 136 million with a prevalence rate of increase 87%. This is the prevalence of diabetes in Gulf countries, and we can find here Saudi Arabia, there is 17.7% prevalence of diabetes within. Also, they can found the IDF report, latest report, 4 million, around 4 million out of 35 million diabetics have living with diabetes, and 1.8 million have the disease but not yet diagnosed. And they are expecting that the number will double by 2045, the number of type 2 diabetes in Saudi Arabia. As we know that the pathophysiology of type 2 diabetes comprises multiple pathophysiological processes ending into hyperglycemia. Type 2 diabetes comprises 90% of those patients living with diabetes. And this rising number, it is due to the complex interplay between socioeconomic, demographic, environmental, and genetic factors. The key contributor of this pathophysiological process is the urbanization, aging population, sedentary life, and increasing obesity. Now we will discuss the most important enemy in our therapeutic success during the management of type 2 diabetes is the clinical inertia or the therapeutic inertia, which we can define it as a delay in treatment intensification despite suboptimal glycemic control, or failure to de-intensify management when people are overtreated. This be exposing the patient to the complication of diabetes, exposing the patient to more hyperglycemia, more hypoglycemia, and diabetes-associated complication, and hence reducing the life expectancy. This clinical or therapeutic inertia, we can find it affecting almost 50% of patients with type 2 diabetes due to multiple factors, maybe related to the doctor, related to the patient, related to the health system. And so that to overcome this therapeutic inertia, we have to address it as a priority to reduce the burden of diabetes and its complication. Here we can see the percentage of therapeutic inertia, or the percentage of diabetics which are not attaining their goal. And you can find here in Saudi Arabia, it ranging from 59% to 70.7%. This is the factor which is the cause of therapeutic inertia, and the physician factor almost the largest part is related to the physician inertia, 50%. Maybe multiple factors. The most important, which is the underestimating the doctrine, underestimating the importance of intensification of the therapy, as well as the poor doctor-patient relationship. Also, sometimes the failure to set or monitor the treatment regimens. 30% related to the patient, maybe due to poor physician-patient control, maybe due to the side effect. The patient is afraid of the side effects, feeling of hypoglycemia. That's why he doesn't want to be in goal, or he is underestimating the situation. The healthcare system related, which is around 20%, due to no available guidelines, no decision support, no registering, and poor communication between the physician and the staff. Here we can see the Discover study. It represents the early versus late intensification of the glucose-lowering therapy in those patients with type 2, and they clarify that late intensification of the therapy, they are reducing the likelihood reaching to a recommended treatment goal. Also here we can see the immediate treatment intensification, improving the glycemic control through decreasing hemoglobin A1C and through increasing number of patients who attain goal below 7. So till now, we reach that early treatment intensification is mandatory, and it is important for management of type 2 diabetes to avoid complication and improve quality of life. Here is the latest guidelines as regard our glycemic targets and our goals, which is to be individualized. Individualized glycemic targets with patient-centered treatment goal. This is the mandatory for all patients with type 2 diabetes. Ideally, to keep the blood glucose near normal with pre-prandial level between 80 to 130, postprandial level below 180, hemoglobin A1C for most of adults below 7%, unless this patient with high incidence of hypoglycemia, patient with long-standing disease, patient with short life expectancy, or those who has multiple comorbidities, established cardiovascular, patient limited resources, and patient preferences refuse a lot of medication. That's why we can less stringent control up to 8%. For those patients who are using the continuous glucose monitoring machines, we have the ambulatory glucose profile with these visual cues that represent, there is a time and range which is representing the assessment of glycemic control, and we wanted more than 70%. And this is the time below and above range, which evaluating the treatment regimen. And we want to find the time below range less than 4% and less than 54%, less than 1%. So how we can manage the patients? Our management plans according to the latest consensus reported by the American Diabetic Association and the European Association for Study Diabetes. They recommend the holistic person-centered approach. This holistic person-centered approach for type 2 diabetes comprises a lot of things. Here, first of all, the glycemic control, the glycemic management, either with monotherapy or combined medication. However, we can use the highest efficiency medication without occurrence of hypoglycemia. Also, the choice of glucose-lowering medication according to the patient comorbidities. Is a patient with atherosclerotic cardiovascular disease, is patient with heart failure, chronic kidney disease, so we can give and choose the medication with cardio-renal protection. Also, they emphasize the importance of weight management and to reaching their goal. Also, this cardiovascular risk factor management in form of treatment of hypertension, less lipidemia, smoking cessation. This is the holistic approach. We will, after that, we will explain more. This table shows the currently present glucose lowering medication we are using in type 2 diabetes, and it represents the drug specific and patient factor to consider when to select the medication. They certified the medication according to their efficiency, to their effect on hypoglycemia, their effect on weight, their effect on cardiovascular outcomes after the Diabetes studies, and the renal outcome and special consideration. We can find here, they found that the SGLT2 receptor inhibitors, they have cardio-renal protective properties after the Diabetes studies. And this issue explained by Dr. Ahmed. This is the GLP-1, also with the cardiovascular outcome and renal benefit. So when we will see and we will tell SGL2 and GLP-1 with cardiovascular benefits, so we can highlight these drugs. Certain points here, just to make the intensification properly, also advised and recommended by the latest guidelines from the AGA and ESG, that is the first line therapy depend on patient comorbidity. They are splitting patient with comorbidities and the patient without comorbidities. Comorbidities in form of atherosclerotic cardiovascular disease, either established or presence of high risk factor, if presence heart failure or chronic kidney disease. This first line of management, it will include the comprehensive lifestyle modification plus or minus metformin. Pharmacotherapy should be started once type 2 diabetes diagnosed. Also, the choice of pharmacological agent, as we mentioned, according to patient comorbidity, drug efficacy, low its effect on hypoglycemia, the cardiovascular safety, its effect on weight, its cost, and patient preference. Also, they recommend early combination at initiation of medication, at initiation of therapy to extend the time to treatment failure. So when I will combine, especially if the A1C 1.5 to 2% above the glycemic target, this to give us greater efficacy and the durability of treatment. Early insulin introduction, a lot of doctors afraid, and a lot of patients as well, afraid to early introduce insulin to their regimen, but there is sometimes we have the justification to start, like if there is severe hyperglycemia, either by symptoms or blood glucose above 300, A1C above 10%, or the presence of catabolic feature in form of weight loss, hypertriglyceridemia, or the risk ketosis. Also, early intensification should not be delayed, and we have to evaluate this, the management Q3 months if the patient not controlled, and the Q6 months if the patient is controlled. And they started to say this: if the type 2 diabetes patient with established atherosclerotic cardiovascular disease or with indicator, or the patient has chronic kidney disease or heart failure, so we have to start with medication with glucose lowering effect and comprehensive cardiovascular risk reduction, independent of the A1C, independent of starting of metformin, and in consideration of patient-specific factor. This is the GLP-1 receptor agonist and the SGLT2 inhibitor with proven cardiovascular benefits. In those patients without comorbidities, so we have to start with metformin, and the choice of a second agent according to the efficacy, avoidance of side effect, hypoglycemia, and weight gain, cost, and the patient the same concept. Sometimes we are in need of injectable therapy with a greater potency, especially in those with longer duration, and we are preferring the basal insulin. Sometimes we are preferred to start GLP-1 receptor agonist before insulin in certain, in absence of these criteria, what we mentioned before of starting insulin. This, the combination is recommended for greater efficacy and durability. Treatment intensification: before we are used to stepwise the medication. Now it is not necessarily to stepwise only the medication above metformin to maintain A1C target, but we can wean from the current regimen considering hypoglycemia. So either we will add or we will remove medication. This is reflecting a tailoring of a regimen in alignment of patient-centered treatment goal. This is the end of the conclusion of the recommendation, that they are the left side of the figure is the patient, those patients with comorbidities, either atherosclerotic cardiovascular disease or indicator of high risk, patients with heart failure, patients with chronic kidney disease. In those patients with atherosclerotic cardiovascular disease, we have to start with GLP-1 or SGLT2 inhibitor. If one is not enough, we can add the other. And after that, we can titrate according what we mentioned, the criteria of the medication we can do. This is for heart failure, better to start with SGLT2, proven effect with heart failure benefit. And those patients with chronic kidney disease, SGLT2 first and then GLP-1. For the right side of the figure, they are those patients without comorbidities. They recommended to start with the medication with the higher efficiency, like the GLP-1, insulin combination therapy, either oral or injectable combination, or after that we can use the intermediate like DPP-4, and the management of weight gain, management of the obesity according to the guidelines. After that, Dr. Bashar will discuss it. So my message is to individualize target with patient according to patient-centered treatment goals, personalized management with patient-centered approach, and intensify treatment according to the recent guideline to prevent complication and improve quality of life. Thank you.